everybody. Welcome to our session on guidance and the guidelines. I'm really excited that everyone came back after the break and is with us for the remainder of the afternoon. I'm Nina Crowley. I'm the Bariatric Surgery Program Coordinator and Dietitian at my hospital, MUSC in Charleston. And today we have two other fantastic speakers. We have Dr. Christopher Still, who's the Director at the Geisinger Center for Nutrition and Weight Management, and he is joined by Cassie. Cassie's story is a registered dietitian, and you guys all know her, right? So let's cut to the chase, right? You all want to hear what we're here to talk about. So I get to start with a little bit of an update on the ASMBS nutritional guidelines, and so I thought it would be a good idea first to talk through a couple terms and make sure everybody's up to speed with what we're all talking about here. So the ASMBS is the American Society of Metabolic and Bariatric Surgery. It's our professional organization in bariatrics that we all, many of us are members of, and they're our accrediting body, and they give us guidelines through consensus with our peers and our other professionals. Hopefully everybody knows what a registered dietitian is, but we are the food and nutrition experts, and we have to go to school for a really long time, and we don't ever get paid enough. Is that up there? But we do go to school for quite a while. And clinical practice guidelines, that's what we're going to be talking about today. This is what statements are that are recommendations intended to optimize patient care, and they're informed by a systematic review of the evidence. The systematic review is a process of evaluating evidence that's out there, and it's graded. And so here you can see that the grades are A, B, C, and D. And if you actually get this paper that we're talking about, the guidelines, and looked through them, they have the grading and the level of evidence. So we're not going to get into the weeds with that. I just wanted to go through and let you know that anything that's a grade A is your strongest evidence, going down to the grade D, and then level of evidence 1 through 4 as well. A little bit deeper into this, I wanted to make sure that we knew what nutrients were. Nutrients are macronutrients and micronutrients. The macronutrients, you probably know, are protein, carbohydrate, and fat. And the micronutrients are essential nutrients and trace minerals that are required in trace amounts in the body. Cassie's going to go through that in sort of a wrap-up session in a little bit more detail. But our vitamins are organic compounds required by humans in small amounts from the diet. There are things that are water-soluble, and that's your vitamin C, and then your whole host of B vitamins, your fat-soluble vitamins, or your ADEK, A, D, E, and K. And then under minerals, you have your larger minerals, your calcium and magnesium, and then your trace minerals, the ones you probably are familiar with: iron, zinc, copper, chromium, selenium, and there's a couple others. So that's kind of the language that we'll be using. I wanted to highlight, too, a little bit about the history of nutritional guidelines within our association, mainly to show you that the first time we ever really had some guidelines was in 2008. And so I've heard already today that many of you have had your surgery before then, and so we really didn't have a lot of consensus before then on what exactly the proper recommendations would be. We've had other groups collaborate on some guidelines in between in 2009, 10, and in 13. But then this year, which is the primary focus of today's talk, was the micronutrient update from the ASMBS Integrated Health group. And so that's our nutritional guidelines specifically focused on micronutrients. I know when we talk about this topic, it's a little bit difficult because, as you guys have probably experienced, every program seems to do it a little bit different. Every doctor, every dietitian, there's a lot of differences in what recommendations are. I think we can all agree that patients need to be screened before surgery, and the guidelines support that. There's prevention recommendations that are pretty solid as far as what would prevent deficiency, and then we can all also agree that you need follow-up with someone who's specialized in bariatric surgery so that you can have those people who are up to date on all of the things that are coming out and are cutting edge, which it's evolving rapidly, finally. I think also we can agree that you want to check in with lab work annually and with your providers, whether or not that's someone on the bariatric team or a primary care person who's got some, vested interest in that. So those are sort of where we all agree. You see differences in individualized care, of course. There's not a one-size-fits-all approach. If there were, there would be one company that, provided that in a vitamin, and it surely would be once a day if we could design it in an ideal fashion. So you have to look at the individual patient, the provider's experience and what other things that they've encountered in their patient care, their knowledge of the most recent guidelines, and then treatment or repletion based on the deficiencies. And the deeper we get into the paper, I think the more confusing it is even for me on which labs to check and what these deficiencies are based on. And so we'll try not to get too detailed, but I did want to give you more than you might be getting without looking into these guidelines. I also, of course, had to put in a plug for one of the recommendations that is consistent in that medical nutrition therapy provided by a registered dietitian nutritionist as part of your interdisciplinary team is strongly recommended, and part of that is the assessment, diagnosis, interventions, monitoring, and evaluation that the dietitians do. They focus the latest guidelines on the assessment of pre and post-op, screening, the supplementation, and then the repletion of any deficiencies that are found. So you want to optimize patients before they have surgery, education on deficiencies that are associated individually with the anatomy based on the surgery type, and hopefully your programs have a strong component involving a dietitian. So I broke these up next to talk through the three kind of subsets of the vitamins that are highlighted in this 2016 update. Vitamin B1, which is thiamine, vitamin B12, cobalamin, and folic acid or folate. And so the first bullet point here is really the, from the recommendations, the more or most recommended lab to check to assess if someone has a deficiency. And then they have other labs. Even looking through these, I know there's some things that our program needs to do to get up to speed with the guidelines, and it's really hard to stay abreast of all these changes, especially when you factor in things like cost. I know we've been checking vitamin B6 on our patients, and that's not in this set of lab work, and for our self-pay patients, it was like $200 a test, and so I've got to reconsider if that's in line with the evidence. Screening for your fat-soluble vitamins. I think this set of guidelines focused a lot more on the fat-soluble vitamins than they had in the past. So vitamin D, vitamin A, vitamin E, and vitamin K for all the types of surgeries. And your minerals, so calcium, iron, zinc, and copper. I'll talk at the closing about which recommendations are new on this recent update, but I think part of what's your role here is being the advocate to your programs. You're probably learning some new So on the middle column would be your amount that's now recommended to prevent deficiency. So that's, I tell patients that's your lab work looks perfect. That's what you're taking. And if you're for some reason in one of these higher risk groups, this would be the last column. This is again to prevent deficiency. And so this is not yet to where you're being deficient. This is like for the, folate, you're a childbearing age woman, which is, like 70% of our patients have a higher folate requirement. Based on type of surgery, the duodenal switch patients need more of the fat-soluble vitamins because they're not absorbing the fat as much. And the calcium recommendations differ there as well. Iron has gone up quite a bit, specific populations as well, and then copper and zinc, which we really didn't have much guidance on before on a good number. So again, not that you need to memorize these, I just wanted to familiarize you with them so you had some background when you're looking at that handout. And I also wanted to just make a point that when you look at the grading, the only grade A recommendations in the entire 79 guideline update are actually 4 related to vitamin D. So the strongest evidence is that pre-surgery patients be checked for calcium and vitamin D status before surgery, and that when you are supplementing or taking vitamin D3, you need less of it than you would the vitamin D2 because it's better absorbed. But also that you can use the vitamin D2 to replete in that high dosage, that 50,000 many of you have probably taken, that actually was grade A evidence that would replete patients. Some patients may not respond to that type and you may have to switch, but just wanted to again highlight that was on here. And then again, your vitamin D3 is often more recommended, but was nice to see that both can be efficacious at changing those levels for the better. So really the new to you recommendations and the new to us were that the vitamin B1 or thiamine levels really increased from a couple milligrams a day to 12 as a baseline. So a lot of the formulations are accommodating that so that your specialized multivitamin would now have that much thiamine. When you look at it, I know it's super confusing because we talk about these as a individual vitamin, but when you look at a vitamin, it has different levels of all of these in there. So it seems a little bit backwards, but this is something that they're adjusting and making those changes to for those specialized bariatric vitamins. Preferably 50 to 100, though, is their recommendation. And so most often you would have to take an additional supplement there if you wanted to get to that dose. The B12 was now recommended for all the procedures at the level of 350 to 500. And the folic acid or folate was increased for the childbearing female patients. Vitamin A, they gave us a range of 5 to 10,000, and the higher 10,000 was for the switch patients. The vitamin D, again, 3,000 IU, I think that was pretty common, but now added in there that the D2 can replete a low level. And then vitamin E, they recommended here 15. I think this is lower than in prior years, and converting milligrams to IU is, a whole nother conversion and a story there. But that's there now. And vitamin K, which is another big recommendation. I think I see a lot of variation in the what's in the supplements there with the K. So 90 to 120 for the bypass in the sleeve, and then 300 for the switch. Calcium went down a little bit for the bypass and the sleeve patients, and up, or I think that may have been talked about somewhere, but 1,800 or 20 to 2,400 for the switch, and that can be taken here as carbonate with meals or calcium citrate with or without. And that was a change in some recommendations because I think forever we've been talking about just the citrate form. Iron, again, I think Cassie will talk about this a little bit, but there was an increase for most all patients, 45 to 60. I see so much iron deficiency in my own patients that if we get them taking more on a baseline level, I think that will help from the deficiency standpoint. And then zinc was an increase depending on surgery type, as well as copper now is a recommendation in there. So you're probably maybe even more confused than when we started, but I wanted to make sure that you had some familiarity with these guidelines, with what these new recommendations are, and especially, advocating for your team to check through those and make sure that they're adapting their process as well. So my main message is to commit to yearly annual visits with your team, with a specialist. Utilize Dr. Still will talk about the nutrition-focused physical assessment, because my take-home as a dietitian is, oh my gosh, there's all sorts of labs, there's all sorts of vitamins, it's completely confusing. But some of the things that you can do looking at a patient's eyes and skin and hair and nails, that will tell you if they're deficient. So regardless of what the lab work is and all of that. So I think there's going to be more on that to come. Keep up to date with your guidelines, or make sure that your provider is. And remember that new guidelines are supporting additional lab work, so that needs to get into the process. And if you are checked and have normal labs, be sure that you continue to monitor that. I have a lot of patients who at one point had high B12, and they just stopped taking B12 forever. And so you want to be sure to check in with those every year, so that you know how those levels are doing. Also, there's lots of pathways to getting in your recommended vitamins and minerals. It's very highly patient-specific, as well as all sorts of other factors. So there may be lots of pathways to that. And don't rely on that primary care saying, oh yeah, we checked all your labs. We don't know what all the labs are. So be more specific there. And don't take complete at face value, right? The gumball vitamins say that they're complete. They can say whatever they want. So, and then finally, that your insides aren't normal after surgery. So even though you may look normal and someone may assess that you're at a healthy weight, you will always need additional supplementation based on your anatomy change. All right, I went over. You're gonna have to catch up.
Not a problem.
Thank you.
Very nice job. Thank you, Nina. Good afternoon, everybody. It is certainly a pleasure to be back to talk to you all. As Nina said, I am a physician, and I'm going to tell you, not because I'm proud of what this is, but the term you may not have heard too much is an obesity medicine specialist. So it's a growing, up-and-coming field. We're board certified, and I just put that out to you that there is more and more obesity medicine specialists throughout the country. And so you may want to look for one in your area coming soon. There were internal medicine, family practice, any really medical board with an additional training. So what I've been asked to do today is talk about recognizing the signs and symptoms and what the annual labs will tell you. This is really a lecture that I put a lot of material in for you. So I would just say sit back, relax, because you all will get a copy of these slides. I wouldn't try to write anything down, because I think you'll enjoy it and learn more if you just take it in. Because I really wanted to provide with a lot of different things for you. So I wanted just to show you how behind the 8 ball. I would just show of hands, how many people have had surgery in the room? Almost everybody, right? Okay. So just before surgery, look at how we are behind the 8 ball. So this is vitamin and mineral at risk. So this is preoperative deficiency. Vitamin D, as Nina just said, 60 to 70% of patients preoperatively are vitamin D deficient. If you talk about iron deficiency, especially in menstruating females, it's up to 9 to 22%. Thiamine is really most important, at least preoperatively, in African Americans and Hispanic. In the Caucasians, we don't usually see as high of thiamine deficiency preoperatively, but postoperatively, with nausea and vomiting and with GI problems, we can. And I'm going to talk about that because that is really the only medical emergency, I think, from a medicine standpoint, postoperatively. I think it's really important. B12 deficiency, also very, very important and very common preoperatively, and adequate supplementation postoperatively is very important. And also zinc. We don't think about zinc, but postoperatively zinc is really important because it's tied to anemia. Zinc, when we take zinc, it inhibits absorption of iron. It binds iron, and then we don't absorb the iron. So those Cold-EES and all those zinc lozenges, you have to watch because it can really impair the absorption of iron and precipitate one's anemia. as Nina says, I think is really important. Post-operative macronutrient deficiencies, it's all really important to know what surgery you had. And I can guarantee everybody in this room knows what surgery they had. However, I see a lot of patients post-op, and I said, did you have the sleeve or the bypass? And then I'm like, what did you do the last 6 months prior to this? So I think that they don't really fully understand. So I really think that's really important that then the restrictive procedures, the band and the vertical gastroplasty, which we really don't do anymore, but the sleeve gastrectomy, the duodenal or the Roux-en-Y gastric bypass, and the duodenal switch, as we go through those more malabsorptive procedures, it goes to stand to reason we're much higher risk of micronutrient deficiencies postoperatively. So this is one of the slides that I think you'll like at home. Not too much here, but I think it's a nice diagram with regards to surgery. So most people either have a sleeve gastrectomy, so 90% of the stomach is removed, or the gastric bypass, where it bypasses the majority of the stomach and the first 150 centimeters of the small bowel. And when you get home, you can see all these macronutrients and nutrients that are absorbed as normal anatomy. So I'm going to give you the highlights in just a minute. So post-operative data, adherence to directives from our healthcare provider decreases as patients go on from surgery. And that only stands to reason. The good news is with Center of Excellences, we're keeping more and more data long-term. But the problem is primary care physicians don't have a good handle on, number one, what surgery you just had, and number two, what you need post-operative annual check. So that comes back to you. So you have to be an educated consumer or educated patient and educate your primary care doctor, because they really don't have any clue of what really needs to be done. And I mean that because we try to educate as much we can, but I'll tell you, you really have to have an engaged clinician or physician or healthcare provider with you through this post-op journey. The risk of nutrient deficiency increases as the surgery out, and nutritional deficiency are irreversible in some cases, and that's really scary. So post-op macronutrient deficiency, this just goes that your compliance is terrible. 10 years out, the data found that only a third of you were compliant with micronutrients or with vitamin adherence, and 8 of you never were taking any supplements. So you have to really empower yourself. This is a commitment that you did. You're all very successful. It's a tool, but you need to feed your body in the right way after your tool is in place. So nutrition-related deficiencies may be prevented just with appropriate supplementation, but in order to have appropriate supplementation, you need adequate monitoring. And so that's what I want to talk about today. So as Nina said, signs and symptoms from a physician can be very easy, but we really don't want to wait till I show you these pictures and signs and symptoms, because then it's really far. So that's why I think that you have to do a very specific history and physical, and knowing what type of surgery you had, and supplementation is much easier. So persistent nausea and vomiting, especially post-operatively, that's a real problem with really thiamine, that's the medical emergency that I was talking to you about, and I'll talk about that separately in just a minute. The excessive and rapid weight loss, there's a lot of consequences to that. We all hope it happens, but we really want to make sure that we give our body the building blocks or the nutrients it needs during that weight loss phase. And I'll talk about that. Their fear of eating or gaining weight. There's a lot of food aversions after patients lose weight. All of our life we're trying to lose weight. All of a sudden we lose weight and we're saying, you need to eat more. You need to eat more protein. You need to eat more calories. That's a tough concept for a lot of people. Through their whole life, we've been told to refrain from eating and not eat. So we see more of that than I thought post-operatively. Non-compliance with vitamins and minerals, as I talked about. Other medical conditions that predispose. There's the most common, because of your alteration of your GI tract. The biggest thing is concomitant medications can alter the absorption of the vitamins and minerals that you take. And I think Cassie's going to talk about timing of vitamin supplementation is important. The absorption of interference of other medications, pregnancy, of course, and overall poor self-care self-care and compliance. So compliance is really important. So these are the most common deficiencies that I want to talk about: calcium, vitamin D, and iron. I think those are the most important, followed by B12, folate, and zinc. Those all relate to anemia, so that's why I put it in there. Then selenium, copper, and the fat-soluble vitamins. So they assess the signs and symptoms. As Nina said, the labs only tell you so much that you really have to put into account your signs and symptoms, the surgery that you had, and your labs all together. And that's why I think it's important to work with your primary care physician as a team and make sure he or she understands what type of surgery you had and what symptoms that you're having. So this is one of those things that you'll like when you get home, but this talks about when to do pre-op, 3 months, 6 months, and annually. And we have it broken out here by types of surgery. So not every surgery type needs every 3 months, 6 months. So it's really depending on what surgery you had. Altered absorption as well. So depending on what surgery you had, you're going to have different alteration in absorption. That went back to that figure that I said with regards to the anatomy of the GI tract. But you can see a lot of these are the big one that we do all of those, and those are where I'm going to talk about: calcium, iron, vitamin B12, folate, thiamine, vitamin D. When you get into the duodenal switch, as Nina indicated, you need to pay more attention to the fat-soluble vitamins. So let's talk about the nutrition-focused physical assessment. So hydration status, at least in the pre-op or immediate post-op, is really important. And we can look at very simple things like, are you voiding okay? Are you peeing okay? Is it dark? Moist mucous membrane, stick out your tongue if it's dry as sandpaper, if they stand up and fall down and they're tachycardic, that's all. You don't have to be a rocket scientist to say they're dehydrated. And I think dehydration postoperatively is really important. You guys are all past this stage, but dehydration in and of itself can cause nausea and precipitate vomiting and trigger the portion in our brain to precipitate more nausea. So hydration is really, really important. And as I said, you can look at all these different things for hydration. The tongue, this is what I would say. You're going to see a lot of these pictures. If you have these pictures, if any of your anatomy looks like these pictures, you really need to find a new physician, because you should not let yourself, or he or she should not let yourself get to this far of deficiencies, because these are really exemplifying the nutrition deficiencies. But your tongue also is really important with regards to the B vitamins. As I said, dehydration is important, but this is a big, beefy red tongue. I've seen this actually not in the United States, but when I did some medical mission work over in Haiti. This was really important with regards to B vitamin deficiency. The gums and teeth also, you can get swollen gums with vitamin C. Your taste does change, and I'm sure you can all account for post-operatively what you thought was really good of their drinks before surgery. After surgery, you couldn't stand them. That's one of the reasons you go into ketosis, which is an alternate source of fuel, and your taste change. With deficiencies, it's called dysgeusia and hypogeusia. You have decreased taste or change of taste with some deficiencies of zinc. And you can see there's other ones with regards to the B vitamins, with regards to the mouth dermatitis around your creases of your mouth. Ears and nose, again, zinc deficiency. If it gets this bad, call me, because you really need to get some additional help, because this is really zinc deficiency and B12 and vitamin A deficiency to the nth degree. Now your nails, that's the different things. We can see changes in our nails with just modest deficiency, specifically iron deficiency anemia. You can get paler, your nails will blanch or they become white and they don't bounce back as quickly. So that's one of the things you can look at. Thin nails also can account for iron deficiency or protein deficiency. That's why we'll give you some Knox gelatin, which actually helps with hair and nails. There's also vertical ridges on your nails itself that can be iron deficiency, but that's really at the end stage. Most commonly you see that in just normal aging is the vertical horizontal ridges. And then the curved nail at the end that you see here, That also is pathognomonic for vitamin B12 deficiency. But like I said, you usually have a lot of neurologic symptoms before you're going to, there's other issues going on before you're waiting for your nails to curve up at the end, trust me. Your hair. So everyone worries about their hair. And let me just tell you, I have no sympathy for you guys because my hair won't grow back, yours will. So about 6 months after surgery, your hair will thin, and that's because it's the stress response of the weight loss. So I like to think of it as a tree. If you cut a tree crosswise, you're going to see rings. That means at times when there was a lot of water and not a lot of water, a lot of water and not a lot of water, or a stress on that tree. Same thing with our hair, grows very slowly. So about 4 to 6 months after surgery, your hair will thin. But the good news is, unlike mine, it will grow back. But the most common thing is biotin. I think biotin, regular biotin, will help. Now, if you have deficiencies in zinc, iron, and copper, your hair is going to fall out. It's going to be alopecia. And really, so that's a different thing than your hair thinning. Another thing that you'd see in very rare instances, and hopefully not here in the United States, is corkscrew hair. That's vitamin C deficiency. That's when you actually see with scurvy and things. So I hope you'll never see that or hear about that. But those are the neat clinical findings that you can see. So the anemias. Everyone thinks about just iron, but really iron is just one part. There's B12 deficiency, which is it's not a macrocytic anemia, it's not a microcytic anemia of iron deficiency, it's a it's big cells. And so the cells don't divide when they should because of lack of B12. Okay, Cassie? So also the folic acid can cause anemia. And also what I told you, remember the zinc, because the zinc binds to the iron and it doesn't allow the absorption. These are the requirements. You heard about them, but they're in here for your edification. Those are the ones that I would like you to print off and take to your primary care physician because they're not hard. He or she, trust me, will appreciate it because they're like, well, what should we check? And now you have them and what frequency. As you guys, as patients, and we know 75 to 80% are women and ages are younger and younger, one of the big things besides iron deficiency anemia is bone health and osteoporosis. So I really think that's really important because I just showed you that 60% of patients preoperatively are vitamin D deficient. You really need to be on the ball postoperatively. So there are some things you can check. It's your PTH and vitamin D. So PTH really it goes up with decrease in calcium and decrease in vitamin D. So just because your parathyroid hormone, and people say, oh, I don't have a thyroid problem. Your parathyroid hormones are the hormone glands on the outer sides of your thyroids. They regulate how much bone resorption or how much calcium is sucked out versus put in. So it's really important that you check your PTH every year because that's going to show you your bone health. And as we get older and go through menopause, our PTH goes up because our bone density decreases. So it's a double whammy as we get older. So PTH and vitamin D, and as Nina said, the calcium should be in the form of calcium citrate. That's much better absorbed. So this is really the only medical emergency, as I said, is thiamine deficiency, and it's usually, not always, in the first 6 months after surgery. But what happens is you have nausea, you have altered GI tract, and you have continued nausea and vomiting. And so what happens is your B1 or thiamine goes intracellular. And the problem is it's in the hospital. Because when you go to the hospital, they give you IV fluids and they give you D5, half normal saline, and it's the dextrose, the sugar, that just puts the thiamine plummets intracellular. And that's when you can get nystagmus, ataxia, and that can progress to an irreversible pontine stroke. So really, thiamine is really important. Everyone thinks B12 because they get ataxic and nystagmus, but it takes months to become B12 deficient. Months. It takes days to become thiamine deficient. But you guys are all past that. But we always say anybody that comes in, doesn't matter if you're 1 day out or 10 years out, in the ER with nausea and vomiting, always give thiamine. It's cheap and it will maybe save someone's life. So I'm really going over, so I'm going to just move on to the thiamine. We talked about the thiamine. The fat-soluble vitamins A, D, E, and K, most important for the duodenal switch patients because, as Nina said, the more malabsorption, the problem you have with the A, D, E, and K. It sounds great to the patients in the beginning, but it's really can be expensive, and that really they need to be on top of things because I have seen fat-soluble vitamin deficiency, especially in the BPD patients, further out, and that doesn't take that long to become fat-soluble deficient. People think, oh, we have extra adiposity, we don't need it. Not true. You really need, you do need the fat-soluble vitamins. Muscle health is important in protein. We all know that. As we lose weight, we decrease our lean body mass, and when we decrease our lean body mass, that's our protein stores. So adequate protein is really important, and in the immediate post-operative period, adequate protein helps with nausea and vomiting. So if you go in and you're dehydrated, just giving some albumin or some protein really helps with that cycle of nausea and vomiting. So in summary, understand what type of surgery you had, and I'm sure you all know, or going to have, because that will dictate your nutrient absorption. Know what labs you need to be checked, and hopefully with this lecture, with our lecture, 3 of us today, you will have all that. Educate your primary care on the type of surgery you had and what needs to be done. And then take the responsibility of checking yourself. We usually say, okay, on your anniversary of your surgery. And in the first, say, 5 years, everyone knows, June 13th, 1993, I had my surgery. But the further you get out, you forget. So I always say on your birthday, that's a present to you. You should check your lab. So happy birthday, everybody. Thank you for your time.
Hello, everybody. My name is Cassie. Just a little bit about the amount of nutrition nerd I have in me. I loved micronutrients when I was in school. So we have to do all kinds of nutrition classes. That was the one I was drawn to. So this is like my favorite topic in the whole world. And there are dietitians that only study like vitamin C their whole life. So there's so much to know about all these different vitamins and minerals. So I just want to say that, everything we're talking about today is a lot of information. We've given you that handout so that you can have it, and then also these slides will be available for you afterwards. And then one other thing that I wanted to mention, because I don't say it anywhere in my presentation, but it came to mind as Nina and Chris were talking, something that a lot of providers and programs don't tell you is that you should be fasting prior to your lab draw. So certain vitamin and mineral supplements, if you take them within 12 hours or so prior to the lab draw, it could falsely elevate that specific test that they're looking for. So just to be safe, I recommend waiting a whole day, 24 hours prior to your lab draw to take your vitamins. So what do most of us do when we go to the dentist, right? We're like flossing and brushing and doing everything excessively. So I see that a lot with the patients too, with my patients that I counsel. They're taking their vitamins and all of a sudden they're getting these elevated B12 levels, but that's just a false elevation. So I wanted to note that really quickly. Okay, so Chris and Nina just spoke. Now I'm sending you off to the vitamin store to get what you need. How do you feel? Confident? You know what you can find? So I don't know about you, but if I walk into Sprouts, or this is a Sprouts in my local area, if I walk in, I feel a little bit overwhelmed because there's so many different supplement brands and companies and claims on the bottle. So that's what we're going to talk a little bit about today. We only have a small amount of time, so just introducing you to it, and I'm going to talk you through it as best as I can. So by the end of this, hopefully you feel a little bit more confident when you're choosing your supplements and knowing what to look for, especially if you have the unique nutritional needs of having bariatric surgery. So we're going to go over the forms, quality, and dosing. So we'll look at quality, the dose, dissolution, or how it breaks down, claims, timing, and your willingness to take them. So quality. Does the FDA regulate supplements? Oh my gosh, everybody says no. That's not actually true. It's just a myth. They do regulate supplements. There's just a little caveat to that. So since 1994, the FDA has regulated dietary supplements, and dietary supplements include vitamins, minerals, botanicals, amino acids, enzymes, probiotics, and metabolites. And since 2007, the FDA established something called Current Good Manufacturing Practice, CGMP regulations. And this means that companies have to ensure that their product has the identity of what they're claiming, the purity, the strength, and the composition of what's actually in the product. Here's the catch. The FDA is required to take action if a supplement is misbranded or adulterated after it comes to market. So what the catch is that the FDA does not do pre-market testing prior to a product being launched. It's only if there's an adverse event or it's reported to them. So that's where that misconception can be. The FDA does regulate dietary supplements. They don't do it before it comes to market, which means anybody can produce a dietary supplement and sell it. So God bless him, my neighbor Jason. He's a personal trainer. He's like the epitome of Ken Barbie doll who does CrossFit. Okay, so this is who I live next to. And he tells me one day that in all of his, great fitness mind, and he loves supplements just like most trainers do, sorry to generalize here, but he wants to develop a protein supplement. So he's like, I'm going to San Diego this weekend, I'm gonna make my own protein supplement line. I'm like, oh, that's cool, how are you doing that? Oh, it's great, you just go to this building and you pick out what you want and then you can make a label and put it on. And that's literally what he did. So Jason, I love you if you ever watch this. But that's what I mean. Anybody can make a supplement, they can put a label on it, and they can take it out to market, okay? They do have to follow those GMP by law from the FDA, and if they don't, that's when they can get in trouble. But how many products are on the market when you go to Sprouts? Like 2, 10? I think 50,000 was the latest data that I saw. So the problem is that because they're not regulated, because the FDA doesn't regulate products before coming to market, sometimes companies can launch something and not follow those practices, those GMP practices. So what do you have to look at? Trusted brands. Just like Nina said with Complete Vitamins, I think probably every brand will tell you they're a trusted brand and why they are. So how do you assess if they're a trusted brand? One, make sure that they follow GMP facility practices, which they should be able to tell you. Is there any third-party oversight within the company? So there's some seals of approval that are out there on the market. You may have seen, and Nature Made has been doing a lot of commercials lately. Have you guys seen that? Like USP seal, so that's there and available. Do they have a research and development team? So some of the larger manufacturers of vitamin and mineral supplements will have a complete entire branch dedicated not to sales, not to marketing, but only to clinical advancement, okay? So there's a research and development side of the table. They're involved in research studies, so that's a big indicator for me on if they're a reputable company, because most of them are going to tell you, obviously, that they're a trusted brand. Probably Jason's protein powder has a little sticker on it that says, trust me, I'm a personal trainer. Okay. So quality doesn't need a seal, not necessarily. So the first step is that you want to make sure that the brand that you're choosing is following those GMP practices, that they are able to prove that they have what they say they have in the bottle, that they're testing before they make the product, during the process, that they're testing their product towards expiration date. And then here's some websites if you want, because there are some third-party company seals. If a company elects to pay for this, they can do that. So you will see that sometimes. All right. One of my biggest things as a dietitian, how to read the label. Of course, I wouldn't be a dietitian without having a label, right, Nina? So first, let's break it down. Obviously, look at the serving size. And I say obviously, but I guess this isn't obvious because I can't tell you how many times I would have patients coming in talking about taking 1 or 2 calcium tablets a day. And I'm like, oh, what brand do you have? And they would name some brand that I'm familiar with, let's say. And I would say back, well, you need to take 6 of those, in fact, to get up to 1,200 milligrams of calcium. So look at the label, make sure you understand the dose. You don't have to worry about the percent daily value, but definitely looking at the quantity. So now that you have that nice table in front of you, that gives you a little bit more information as far as how much you need each day, and you can compare that when you're looking at things like multivitamins. And I want to point out numbers 7, 6, 10, and 11. If it doesn't have that on the bottle or packaging, run far, far away. That's a really good sign that it's not following practices as labeled by or as listed by the FDA. You have to have contact information for the company, and that's very important because if you did happen to have some adverse event with a supplement you were taking, you should report that to the company, and then they are supposed to, by law, report that to the FDA. So that's why that's on there. Another thing, if it doesn't, especially on a multivitamin, if it doesn't tell you the source of the nutrient. So see under vitamin A, there's a bunch of stuff listed under there. That's a good thing. We want to know the sources of the nutrients, especially if you have an existing deficiency. That's when we'll want to get a little bit more cautious on those things. Same thing, if it doesn't have a source listed there or in the ingredients, run away from that particular product. You should always have that. So complete multivitamin, I'm glad you brought this up. Guess we both are on the same line. I Googled images. I was looking for images for this particular part, but I didn't want to throw a bunch of stuff up there. And I put complete multivitamin, and again, on the image side on Google, all the multivitamins that I saw said complete. But when you turn them around, they all have different amounts of different things, right? So let's talk about the vitamins and minerals. There's 13 vitamins and there's 19 minerals, including the trace minerals. So there's 26 different vitamins and minerals. So a real quick and dirty way to look at your multivitamin, besides looking at the dose and the amount that it contains of a particular nutrient, is to look at how many nutrients are in it. If it has 10 or less things, that's not close to 29. Most of them will have, let's go with like 19 to 25, 26, somewhere in there. Okay? I don't think sodium needs to be in your multivitamin. We all get plenty of that. But there are 29 vitamins and minerals. So if something says complete and it has 9 things in it, that to me isn't complete. So I guess we don't really have an established definition of what that means. More on minerals. Minerals are naturally bound to other substances. So when we're in supplements as well, a mineral is bound to something, and that will impact its bioavailability. So you hear a lot of talk about citrate, carbonate, malate, palmitate. Like, you'll hear all kinds of things, and I'm not going to get into it too much right now, but in general, after surgery, oxides are more poorly absorbed than citrates and malates. Chelated vitamins are the most readily absorbed, but we don't have a lot of good scientific literature on this at this point. Okay, right now we're getting a lot of vitamin and mineral deficiency studies coming out in the last 5 years or so. We know the deficiency rates are high and that they're increasing and that the risk for vitamin and mineral deficiencies increases as you progress from surgery, but we haven't done a ton of studies on bariatric specific surgery populations on different forms of minerals or vitamins. So just know that, okay? So let's talk about your form options. There's tablets, right? They're cost effective. They're usually a higher potency. Some negatives to them, they might be too large. They may not break down in a low acidic environment, which if you've had bariatric surgery, besides an adjustable gastric band, you have a low acidic environment. There's capsules, which disintegrate quickly and then can be opened. If you want to make sure your capsule disintegrates quickly, you can put it in your mouth. This is fun. It's a little taste test to try. I'll make Chris do it later. Do like a show and tell. You put it in your mouth and rest it on your tongue. It should break down after about 30 seconds or so. Okay, that's how you know those capsules are working. But you can also open them and put them into something. So a lot of people like to do that. Soft gels are designed to hold liquids like omega-3 fatty acids or fish oils. Chewables can be more expensive because they cost more to produce, but you'll find there's a lot of tasty options on the market these days. Lozenges are available too. Long-term use of lozenges in certain vitamins can stain your teeth, just FYI. Powders are used for larger quantity of nutrients and they can be added to food. I wanted to throw a caution in there. Anything that's added to a temperature of above about 120 can actually denature or break down the B vitamins, the water-soluble vitamins, so you wouldn't be able to use them. And a lot of my patients like to add either the multivitamin to something or different protein powders to things, so I just wanted to caution that really quick. And then we have liquids, which are easy to drink, more expensive, and they have a shorter shelf life. Lastly, topicals and patches. So topicals, we all know these things, or we've heard stories of if you get a scar, rub some vitamin E on it. If you have sore muscles, soak in Epsom salt. What does that do? That takes the magnesium from the Epsom salt and it puts it into your body to help those sore muscles. But topicals and patches are not considered dietary supplements, so they're not regulated as such by the FDA. So there's been a lot of talk in the last few years about the use of transdermal nutrient delivery. I will not go into it right now. That is not the point of this conversation. However, we have no research to show that those types of delivery options are effective for our patients. And to me, the risk to benefit ratio is far too great. You know, we up here have seen the devastating effects of nutrient deficiencies. You all probably know someone who has had one, or you yourself have suffered from one, and it's not pretty, and some of them are irreversible. So it's not worth the risk to me, even though that would be nice if we could find something like that eventually that works. Right now, I don't see the evidence as being good enough. Is this thing working with the tablet? So if you've ever wanted to know, so I've heard people say, this is really gross, but I don't know if anybody's heard this, like the porta potty, this is like an example some vitamin companies use. They're like, just look at a porta potty and you'll see all these vitamins in there, meaning that it would just go through in your bowel movement. Somebody Google this for me. I've heard it from several people. But if you want to know if your tablet is working, all you have to do is put it in a cup of 98-ish degree water, so to mirror your body temperature. Put it in a cup, shake it around every few minutes, and after 30 minutes or so, the tablet should be pretty much fully dissolved. So that's an easy way to check to see if it's dissolving for you. Bioavailability means the ability to absorb. So does the form of a nutrient matter? Meaning, is it natural versus synthetic? It really depends on the nutrient. So just to give some examples, a synthetic form of vitamin E is half as biologically active as the natural form of vitamin E, where synthetic vitamin C is the same as natural vitamin C. So again, sometimes when you're looking at brands, they'll start talking about this form is better than that. That may or may not be true. It just depends on which particular nutrient we're talking about. It's not universal. Digestive juices play a huge role in your ability to absorb a particular dietary supplement. Stomach acid is key in digesting calcium, magnesium, iron, and B12. So remember, just as Nina stated, the calcium carbonate was added to the guidelines, but it does require stomach acid in order to be absorbed, which is why they state to take it with a meal. However, if you're on metformin, PPIs, or any other medications that continue to reduce stomach acid or affect stomach acid, and if you've had surgery, the stomach acid doesn't have enough time to mix with those different minerals to break apart that mineral to allow it to be absorbed, that is something to consider. Pancreatic enzymes are needed to absorb the fat-soluble vitamins. So I'm going to say purchase supplements wisely. Work with a healthcare provider, not Google, WebMD, or your best friend. They can all be great sources of information on where to get the best cocktail in town, but maybe not on how to prevent deficiencies or choose your supplements. It's almost 5. I'm starting to think of cocktails up here. Don't believe the headlines most of the time. Be cautious with quick fixes. Sound health advice is based on research over time, not just one study that came out. More is not necessarily better. There are certain vitamins and minerals that can be toxic when consumed in excess, or there's certain vitamins and minerals that cause competition for absorption of other vitamins and minerals. So you don't need to take excessive amounts of anything unless, of course, directed by your healthcare provider. Spot false claims. If it says quick, totally safe, no side effects, or cures, dietary supplements are not allowed to state that they cure anything by the FDA, so that's, again, another indication to run. Another one that I should probably add on there is mysterious berry found in the Amazon. So if it's a new berry that somebody found, I mean, I'm not going to spend my money on it. That's all I'm saying. Timing in general, take multivitamin and fat-soluble vitamins with the largest meal of the day. Again, they need pancreatic enzymes in order to be absorbed. So when you're eating a meal that contains some amount of fat, so for me, my largest meal of the day tends to be dinner. For some of you, it might be breakfast. For some of you, it might be lunch. You want that fat, that dietary fat that's in there to stimulate the pancreatic enzymes to allow absorption of the fat-soluble vitamins. So taking the multivitamin or your fat-soluble vitamins like your D with your largest meal of the day is a great idea. Separate large amounts of calcium from other minerals because they compete for absorption in the small intestine by at least 2 hours is the current recommendation. And if you have certain existing nutrient deficiencies, you need to become more cautious with timing. So if you have iron deficiency anemia, for example, you need to take those iron in 2 or 3 doses during the day away from any other mineral because it will compete for absorption. If you remember, iron's a trace mineral, it's small. So those bigger minerals come in and they kind of knock it out, and they're the ones that get absorbed. So the iron goes straight through, you're not absorbing it. So iron deficiency anemia rates for gastric bypass, based on the research around 5 years out, is hovering around 50% right now. So people that have iron deficiency anemia, it's hard to replace that from an oral standpoint if you're not taking it in divided doses. So the ideal routine, like the best of the best that I tell my patients to do, would be a serving of their high-potency multivitamin with iron in the morning, a calcium citrate in mid-morning, calcium citrate mid-afternoon, and then a serving of a high-potency multivitamin with iron in the evening meal. That's my ideal. Does that work for most people? Not all the time. Some are getting better, timers on them. I take vitamin supplements or dietary supplements myself, so I take them about 3 or 4 times a day. So, you've got to, once you establish your routine and get into it and see the benefit of it, it gets a little bit easier. But work with your healthcare provider, obviously, to get a specific routine down for you. So lastly, willingness to take. I think some dietitians' favorite quote is, the best vitamin is the one you're willing to take. And I'm saying kind of. It's a little more specific than that when you have unique nutrition needs. So work with your healthcare providers. You had the surgery to increase your life and live as vitally as you can, and we don't want you to establish these nutrition deficiencies, which can be permanent or lead to devastating consequences. So if you're still a little confused on this and how to choose something, just ask yourself, does this contradict what the majority of people are saying? So if you see a brand on the market that's saying, we do X, Y, and Z, and no one else is saying that, that's probably a red flag. Because if something were tried and true, if it was based on scientific research, everyone would be doing that same thing. That's just one thing. Does what they say make sense? Does it pass your gut feeling test? Like, does it seem right? Is there a meta-analysis involved? How similar were the study subjects to me? Certain brands will say, oh, we studied this, and if you look at the actual study, it has nothing to do with bariatric patients. It has nothing to do with the nutrient that they're talking about, that the nutrient that's in their product. So you have to watch the claims on some dietary supplement manufacturers because they can get a little tricky. And how long was the study? Again, nutrient deficiencies, most of them, besides thiamine, do not show up overnight. They are long-term problems. So people that have had a calcium deficiency due to inadequate dietary calcium intake or inadequate vitamin D levels, they don't know for years after surgery. The last patient I saw with some really bad fractures, she had 5 fractures in the last 6 months, and she was 3 months out from her gastric bypass. So, and their standing height, it's not, she's not getting into accidents or really clumsy or anything. It's just walking, and she'll break an ankle, break a finger, break a wrist. So some of these dietary deficiencies or nutrient deficiencies show up a long time after surgery. So in summary, take your vitamins, go you, and follow up with your healthcare provider. Get your labs checked, please. Just remember, every year, the rest of your life after this, it's so imperative to get your levels checked. And I'm going to say, too, you know your body. All right, so just like Dr. Still said, in the beginning of surgery, you feel all kinds of funky things. Your taste goes away, your things taste weird, no energy, all kinds of stuff is happening. But if you're several years out from surgery and all of a sudden there's a change, there's a good indication that something's going on. So work with your healthcare providers to figure out what that is. Or if you don't have a healthcare provider that's familiar with it, find somebody that is. So that is the conclusion of our session today. We have time for questions, so please come up to the mic.
I have a question.
Yes.
Does cost equal quality with regards to vitamins? Does the more expensive, can a generic vitamin be just as good as a branded vitamin with regards to quality?
In regards to quality, sometimes. So what I would have to do is look at the ingredients, right? So the ingredients will determine the cost. So if something is manufactured with a certain form, so as I said, the oxides are cheaper and they're smaller, so usually that will lend to a smaller pill size, let's say, versus a citrate is more expensive and larger typically. So it depends. The cost doesn't necessarily mean it's better.
Okay.
A cheap product, a less expensive vitamin might be perfectly adequate. But really, when we're looking at that, then I'm going to look to the amount, right? Because none of the over-the-counter supplements meet what you guys need. So there's a lot of extra vitamin supplements you would have to take if you're choosing over-the-counter, just because of the quantity that you need. Okay. I'm going to sit with them.
I sure hope I get all 3 of you answer this. Because when it comes to supplements, you got and this is just the stuff you hear out there on Facebook and the social media, is you hear some people, they go through their practice, they say, oh, just take a couple Flintstone vitamins. So you got that side. And then me being a DS patient, and I hang around some of the other rooms that, not everybody hangs around because of the ADK problems. You get the other that says, there's doctors out there killing people, and if you don't follow this long list of impossible to follow guidelines, and I guess part of the confusion is because, maybe practices aren't sure sometimes, that it's hard to throw the dartboard. Now, maybe, with the new guidelines, it's getting more and more better, but then I'm that 1/3. I'm a guy, so folate. But help me out if y'all can all answer it.
You want to tackle that? Well, I guess I would just say, no matter what the specialty, all providers are different, and they all have these different recommendations. And I always say with dietitians, if there was one answer, we'd just have Dr. Oz, and none of us. But I think it has a lot to do with that there just wasn't recommendations. I mean, even just some of the wacky stuff that's been passed down when you have just surgeons on the team. Earlier today in our group, we were saying we love our surgeons, but after 1 month, get out of here, because they get in our way sometimes, and they don't keep up to date. So they'll say, yeah, take your vitamins. And what they mean is listen to the dietitians and do what they say. But what the patient hears is vitamin. Maybe they didn't say an S, and then they're like, yes, just one forever, So I think there's just a lot of miscommunication, and a lot of each person knows their own lane, but there's low-functioning teams that don't have dietitians in that practice, or there's doctors who really want to be in charge of that and don't loosen the reins on some of that too.
Yeah, I would just say that I think it goes back to what I said before. You need to know what surgery you had, and you need to educate your primary care physician. I'm telling you, as a physician, they have no idea, and so they're going to do the calcium. They're going to do the basic CBC, all this stuff. But you all need more than that, and so that's why if you're and as Nina said, it may not be your surgeon. I mean, it may be either your educated primary care physician, or look for a center of excellence now of the comprehensive care.
Yeah, and lastly, I would just add the handout that you all have. What I hear from a lot of my patients that I deal with, or that I have the privilege of seeing, not deal with, is that they'll say, because I typically keep a small private practice, so I don't see many patients day in and day out. But when I see patients, they're coming to me further out post-op. And what they'll say is, I had my labs drawn 2 years ago and everything was fine. Well, what that means is they probably had a CBC, BMP, they had no nutrition labs assessed. Calcium, serum calcium tells you nothing about your bone storage of calcium. So you have your handout now. Those are all of the those are all the nutrients that need to be screened with different testing options next to it, depending on what your lab is. And something to speak to what Nina was referring to earlier, there are now home lab test companies out on the market. I don't know them. I've never looked at it to look at the cost, but from what I've been hearing is that some people choose to go through these home lab tests instead of through their insurance, and it's actually ends up being less expensive for them. But of course, you have to have that evaluated with a healthcare provider who knows how to interpret those labs too. So.
Hi, I had my gastric sleeve surgery June 20th, so I'm really, really new at this. And my question is, first question is about teeth health. I have the grittiness behind my teeth right now, and I made the mistake of Googling it, so now I feel like all of my teeth are going to fall out tomorrow. So any advice on what's causing that? And also, are there any mouthwashes or preventative care, toothpaste, anything that would help with that?
What is it, gritty?
Gritty?
Yeah, it's either described as gritty, or some people even say it's a little bit of a fuzziness behind the teeth.
So
And it's only behind the teeth.
It's not on your tongue or anything like that?
No.
Well, early on, you can get ketosis, as I said, which is an alternate source of fuel, and you can get that grittiness. And so there's no special mouthwash or toothpaste, but you want to keep your mouth moist with sugar-free candies and things like that. But once you get back on your carbohydrates, that usually will go away.
Okay. And another quick question about vitamins. Is it okay if you have a vitamin that has both iron and calcium in them?
I'll take that one, guys.
Seen that before.
Large amounts of calcium will inhibit iron absorption. That's just a fact. That's general basic anatomy. So when you have an at-risk population, somebody at risk for either anemia or bone disease, I don't feel comfortable chancing that. That's clinically speaking. So from the guideline standpoint, it's still suggested to separate iron and calcium by 2 hours. There are, again, companies on the market that do not claim that, and so they have some studies that they're looking at and that allow them to manufacture that way, I guess. But that's not what the guidelines don't state to do that. They still state to separate iron and calcium. It's not something that I clinically recommend because of the high deficiency rates that we see long term.
Those are two you don't want to fool with. I mean, as I said, so.
Thank you.
I guess I'll just add too, I think when you look at them, what's paired, you may need, I have a lot of patients who really don't end up absorbing much iron no matter what form and when and how, so they would rather, or their GI side effects are so annoying that they'd rather get IV iron and, maybe take the vitamin that doesn't have as much absorption of the iron and then take IV iron. I mean, I've seen that happen too. So it's a lot of piecemeal. It's like if you add, if you take a generic multivitamin, you're piecemealing B12 and K and this and that, or your, multi has iron and you take your calcium separate, or your multi has calcium and you take your iron separate. So there's a lot of just play with that, which is why it's so hard to just say one generic thing to any group.
I have one more. I have one. I know. I have one more on it because one of the saddest nutrient deficiencies I saw a post-op patient. She was 5 years out. She was 38 years old, and she came to me. Actually, she was 7 years out. Sorry, when this happened to her, she was 5 years out. She had had a hysterectomy due to iron deficiency anemia because she could not get that iron level up to where it needed to be and the amount of transfusion she continued to have. So one of her physicians suggested she had a hysterectomy because of it. She was instructed to take 2 Flintstones a day, which has like 18 milligrams of iron or something, nowhere near the amount that she should have been taking. So again, the nutrient deficiencies can be prevented once they're repleted and at the certain level, they can be prevented again. It's not that you're just doomed to a life of all these deficiencies continuing over and over again. So just please make sure you talk to somebody that specializes and knows what they're talking about when it comes to that. So that's all.
My question is more so around absorption. I faithfully take my Bariatric Advantage vitamins. It's supposed to have everything that I need in it besides the calcium. It says to take 3 a day. I do take 3 a day early in the morning, but I usually take it with a protein supplement that has hardly any fat in it. So when you said it needs fat to absorb, how much of that am I actually getting?
So we don't have any studies that have tested this yet. So the reason I'm saying to take it, the most ideal, again, that's the most ideal. So the most ideal time to take any of the fat-soluble vitamins is with a meal. So if you have a protein supplement that even has 1 or 2 grams of fat, that could be enough to stimulate the pancreatic enzymes. You could add a little bit of fat to the protein supplement. So a lot of people have been loving coconut oil or MCT oil or something like that, some flaxseed, something to add fat to it so that you don't have to change your routine. But again, that's for optimal absorption. Okay. So we don't have a study to say one way or the other.
So would I be able to just add a fish oil pill in with my morning vitamins?
That wouldn't be enough. It would need to be a dietary fat. So that's why I'm thinking like a coconut oil or flaxseed.
What
or
surgery did you have?
2% milk.
The sleeve?
Is there an issue with me taking all 3 at one time?
With vitamins, what they taught us in school was divide and conquer. So most vitamins have what's called a threshold, or as you increase the level that you take, your body decreases the absorption that it pulls of the nutrient. So what I tend to say, again, and this goes back to the best vitamin is the one that you're willing to take. So whatever works best for you. If you don't have pre-existing deficiencies and you're very, very good about taking your vitamins and you're taking the 3 and you're taking it with your shake and you're doing it every day, you're probably okay. If you had a deficiency one way or the other, then I would probably get more specific with you about dividing it up.
Okay.
So
Thanks.
You're doing
just again,
great.
depends. Yes, good job.
Hi. So if you are somebody that did in fact have a bad vitamin deficiency problem, and then you get back up to where you're supposed to be, is once a year going to be enough, or are you sort of at a predisposition now where you need to be watching that more closely, or will it take? Is a year going to be enough, or should you do it more frequently?
Once what the research and the guidelines state is that should be assessed then every 3 to 6 months until it's stable. Let's say for what, three draws or something.
We do
Depends
6 months,
on-
yeah. It all depends. There's
the
really no,
nutrient.
but on the nutrient, but I wouldn't go another year. I would do 3 months and then another 3 months, and if that's okay, then go 6 months and then a year. Because it really depends on which nutrient, what surgery you had, and what you're taking. So I wouldn't go another year just because you hit that.
Okay.
And it won't, and if you have a true deficiency with, because this can be costly to a lot of people too, but if you have a true deficiency, 3 months is what the recommendation is that you can recheck.
Okay. All right. Thank you.
And I was just going to say,
The last question after Nina opines.
really quick. I think we as providers need to get a little bit better about being more specific at what we check. You know, we sort of click our thing and it groups all our labs. It's our standard panel. And I think it's important to think about the patient and their deficiency and maybe only checking that one thing that you're deficient in more regularly, but not throwing the whole thing on there just because that's your one click.
Hi. How much effect does dietary calcium have as far as its competition with iron? So most of my meals have some dairy. Should I avoid taking my iron at that time?
Are you iron deficient?
I have been in the past.
That would be the first thing I would do if you are, to try to optimize that.
So
But
what
if you're
I've
not-
been doing, again, because it works for me, because I do eat a lot of dairy and I do get up at least once during the night, is that's when I take my iron.
It's good.
I mean, it's on an empty stomach, but so it could have that effect.
Yeah, and and you can increase your absorption with vitamin C as well
Yeah.
with that. So
Okay, thanks.
very good. All right, James has given us the hook in the back. Thanks, everybody.